What is a tandem transplant? When would you consider a tandem transplant?
Tandem transplant is a application of a stem cell transplant back to back within about 3 to 6 months of the first one, and the goal is to get people into a deep remission. So this was a relatively useful technique when we did not have such good induction treatments pre-transplant in multiple myeloma. So there were randomized clinical trials done in France, which showed that compared to one transplant, a second transplant can benefit at least the patients who were not in a very good partial remission or a complete remission after the first one. So if you had a first transplant and you are not in a great VGPR or complete remission, you could go on have a second transplant to get you there. And those patients who converted did very well. So that was the basis on which tandem transplants were popular for a while. In the United States, there were several centers that did tandem transplant. But then the BMT-CTN in the United States completed a large randomized trial, which randomized patients in the new era, which is the era of good initial therapy, 3-drug initial therapy, transplant, and then maintenance. So with that standard, the tandem transplant did not add much, or a second transplant did not add much to the first transplant. So patients who had a second transplant, then Len maintenance, did the same as the patients who had one transplant, then Len maintenance. In the meanwhile, the European studies still continued to show a small but clear benefit for tandem transplant. So right now, the jury is divided on this. For us, the goalposts have moved, in my opinion, in the United States. For young patients who are transplant eligible, we actually need to get into a deep MRD negative remission. If that is not possible with one transplant, I think you could consider a second transplant at that point as a tandem. On the other hand, if you get a deep, good induction response followed by a single transplant and you're already MRD negative, which most people are going to be in the future, you wouldn't need a second transplant. Therefore, my policy is to be a response adapted for the second transplant question. I hardly have to do it in less than 10% of my patients these days. So I keep the stem cells for a second transplant at relapse if needed, or hopefully never use it if the patient gets a really, really long remission.
So the tandem transplant, believe it or not, it became very popular in the 90s when we didn't have these new therapies. And so actually we had a study from France showing that if you didn't have the maximum response after one transplant, the complete remission, and then you did another one and you achieved the complete remission, 2 was better than 1. But there were some studies that were negative. They didn't show that the second was, advantageous. And there are new studies actually showing that for patients with high-risk disease, 2 may be better than 1. But I think we don't do routinely. I personally don't do. I keep enough stem cells for 2. I use a sandwich the transplant with this new targeted therapy before and after. Occasionally, I do it in certain situations where I think the therapy before didn't work well. If I have a patient who struggled to achieve a response, or rapid progressive disease, and the chemotherapy works, then yes, I say, I'll give it a double dose. There is definitely a dose relation response. There is randomized studies comparing 100 to 200 melphalan, showing 200 better. But the idea is, to achieve the deepest response fast. If you have a rapidly proliferating myeloma, you don't want your myeloma lingering there and developing the resistance. You want to just blast it. You want to eliminate the clone. And so sometimes a tandem transplant changing the conditioning can be reasonable. But because the study were not all positive, it remains a controversial issue based on situation, patient, the genetic of the myeloma.